Good afternoon, everyone. My name is Mariah Earhart, and I am with the Arizona Center for Rural Health, and you are watching the State Office of Rural Health webinar series. Thank you so much for joining us today. As we go through this webinar, please note that the audience is muted during the presentation, but we encourage you to enter your questions into the chat box, and they'll be addressed as they come up. Additionally, this webinar is being recorded to be posted on our website, and you'll receive an email with that link if you want to refer it to a friend or go back and watch anything. I want to take a minute to acknowledge that the University of Arizona is on the land and territories of Indigenous peoples. Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through educational offerings, partnerships, and community service. And with that, I will turn it over to our lovely guests, Dr. Shields and Dr. Cunningham.
Thank you so much. Good afternoon, everyone. We are excited today to be here to share our work on enhancing maternal emergency preparedness through a project we've been doing on a statewide level in Arizona to evaluate a train-the-trainer model for obstetric life support. Next slide. These are some of our disclosures for the research team. Next slide. Over the course of the next hour, we'll be describing disparities in maternal mortality and morbidity, particularly those experienced by rural and other underserved settings. We'll describe what the OBLS training curriculum looks like and the evidence base for how it contributes to reducing health inequities. And then we'd like to share some findings of a couple of ongoing research projects that are intended to promote the scale-up of adoption of this really important training. Next slide. Next slide. So this slide shows data on maternal mortality rates over the past 35 years in the United States. And while there is a clear spike in maternal death during the COVID pandemic, and at this time there were also some administrative changes to definitions of maternal death, this slide, if you click again, Dr. Shields, is that the maternal mortality rate in the United States has been steadily increasing over time. Next slide. Notably, the United States has the highest maternal mortality rate among all developed nations. Next slide. This slide from the Arizona Department of Health Services likewise shows the trend of increasing maternal mortality in recent years in this state as well. People of color are the most impacted. Nationally, Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women. In Arizona, the most pronounced inequities in this regard appear among American Indian and Alaskan Natives, as well as Hispanic and Latina populations, who experience a higher share of pregnancy-related deaths relative to the proportion of their births in this state. Next. There are also significant geographic disparities. This slide illustrates that rural women, according to some older data, have a 39% higher maternal mortality ratio compared to those living in large metropolitan counties. The most recent data that's just been released from the Centers for Disease Control show this trend continues, but that now the maternity ratios in rural areas are over 50% higher than in large urban areas. Next slide. Such geographic disparities are evident in Arizona, where 11% of women of reproductive age live in rural areas, but only account for 11% of women of reproductive age live in rural areas, but account for 17.3% of pregnancy-associated deaths. And you can see on the right-hand side what this distribution looks like by different regions across the state. An important factor impacting maternal mortality and morbidity has been the increase in maternity care deserts across the US. So these are counties where there's a lack of maternity care resources, no hospitals or birth centers offering obstetric care, and no obstetric providers. Half of rural counties are considered to be maternity care deserts, and hundreds more communities are at risk of losing maternity care because of serious financial and workforce challenges that rural hospitals are facing. In Arizona specifically, 6.8% of women had no birthing hospital within 30 minutes compared to the national average of 9.7%, and 20% of birthing people were considered to have received inadequate prenatal care. Again, this is much greater than the national rate of 14.8%. So far, I've been talking exclusively about maternal deaths, but it's also important to recognize that for every one death, there are another 60 cases of severe maternal morbidity. Severe maternal morbidity is estimated to impact over 60,000 patients in the US, so approximately 1.5% of births. However, these estimates don't include prenatal and postpartum health complications. If you include those numbers, this figure rises to approximately 90,000 patients. Importantly, more than 80% of maternal deaths are considered to be preventable. Next slide. This is also the case in Arizona. So here is a review of pregnancy-associated deaths that occurred in 2018 and 2019. It was estimated that 90% of these cases were preventable. And you can see on the right-hand side, the distribution of these deaths by gestational age and also in the postpartum period. So, within 42 days of death, pregnant within 42 days of death and at the time of death were all deemed to be 100% preventable. Next slide. This again is slightly older data that's not accounting yet for COVID infections. So while infections, including COVID and mental health conditions, account for a majority of maternal deaths in the US, unspecified cardiovascular disease is also a leading cause of pregnancy-related deaths, and maternal cardiac arrest is a very common pathway for maternal death. Nonetheless, most medical responders across the care continuum are not adequately trained to recognize and treat maternal medical emergencies, including maternal cardiac arrest. Next slide. These facts suggest a serious deficiency in existing standards for BLS and advanced cardio life support training as they relate to maternal cardiac arrest. And currently, despite published guidelines, if you could click again, there are no national standardized training programs required for maternal medical emergencies and MCA. I apologize for the wonky animation. Click twice to get to the last. Which brings us to obstetric life support. So obstetric life support is a validated simulation-based curriculum designed to equip pre-hospital and hospital-based healthcare workers with the knowledge and skills necessary to prevent, recognize, and manage maternal medical emergencies. And I'm going to hand it over to Dr. Shields to tell you a little bit more about this curriculum and its evidence base.
Thank you so much, Dr. Cunningham. So let's get right in and talk about obstetric life support. As Dr. Cunningham mentioned, this was an educational platform that we developed since 2018. What the course consists of, or the platform, we initially brought together experts from all over and looked at the existing evidence. We actually did a bridge as a lot of the evidence was based in mid-2010, so 2014-15 range. So we did a systematic review to bridge the evidence. And then we went through systematic processes to put together learning objectives and how we would teach those learning objectives. And so what we came up with was a comprehensive manual that has many different focus on different aspects of pregnancy and postpartum care that have to do with the most common etiologies for severe maternal morbidity and mortality, as well as a real deep dive into maternal cardiac arrest, the skills and the knowledge required to appropriately respond to patients that might suffer this rare but devastating issue during pregnancy. And so we developed several algorithms, checklists, and tools that are proprietary Initially, we developed 2 different curricula for hospital-based workers and pre-hospital contexts. We also worked with an international simulation company to develop a customized simulator. We developed and validated megacode scenarios with drivers, as well as cognitive assessments with defensible cut scores and megacode checklists for evaluation of the team leader at the conclusion of each course. We also synchronously developed a train the trainer course, because what was really important to us is scaling this eventually for the rest of the country and the rest of the world. So we developed that particular course to be virtual, so that we could increase access and our instructor pool. This is a busy slide, but what it basically shows is the OBLS curriculum. It's a hybrid curriculum where we have participants do pre-course self-study that was originally contained within a manual that we published with an international publisher as a textbook. It originally included 10 chapters. It focused on things like an overview of normal and abnormal pregnancy physiology, the key modifications to both basic and advanced life support, as well as the common causes and special procedures, as well as other skills like team communication and debriefing. There was an entry exam for our learners, and then they would come for a 1-day instructor-led simulation-based class where they would practice skills and team dynamics. And we use something called rapid cycle deliberate practice, which is a newer way to teach simulation, and it works very well in resuscitation in order to really dig deep and make sure that the skills that were being applied correctly in the correct order, and that there was timely management of the critical response elements to cardiac arrest. Then at the conclusion of the course, every person was assessed as a team leader, managing a maternal cardiac arrest scenario, and we had our instructors would evaluate them using a validated scoring checklist. So the key points that our course covers are things like effective chest compressions, which don't change in a pregnant woman. However, hand placement can change because of the large breast tissue, especially towards the end of pregnancy. We emphasized making sure that compressors were switching out every 2 minutes to avoid fatigue, or every 2 cycles, not overventilating a patient, which can happen quite commonly in cardiac arrest. We also taught the correct placement of pads, accounting for the breast tissue and the pregnancy itself. And then we really focus on something called left uterine displacement, or left lateral uterine displacement, to try to get the uterus off of those major blood vessels that are going back up to the heart. And that applies for anyone who's 20 weeks of pregnancy or greater, or if the fundus of the uterus is at the umbilicus. And so we really teach that skill, and that's quite a new concept, especially for pre-hospital clinicians. We emphasize that medications during CPR do not change in a pregnant or postpartum patient. The only possible exception is fibrinolytics, especially when a surgical procedure might be required for proper resuscitation response. We talk about early advanced airways to reduce the risk of aspiration. That can happen more frequently with higher incidence in pregnant patients. And then we really focus on guiding resuscitation through end-tidal capnography. Again, this is not a new concept, especially for pre-hospital providers and ER physicians, for example. However, it's not something that's seen or practiced a lot, especially on labor and delivery settings. And so this is a really great way to get the teams and the team leader using that as a guide of optimal response. We also talk about a resuscitative cesarean delivery. You may have heard that called perimortem C-section or resuscitative hysterotomy. We really landed on resuscitative cesarean delivery because it's a more recognizable term, I think, to non-obstetric healthcare workers, where if you say you're going to be doing a cesarean delivery, for example, down in the ER, people would know what that was. And adding resuscitative, because it really is part of the resuscitation response that can save a pregnant patient's life. So here you just see an example. This is actually in a real patient who we're doing a vertical skin incision on, but it would replicate what you need to do at the time of resuscitative cesarean delivery. at ideally 4 minutes after pulselessness if you do not have return of spontaneous circulation. Our course content not only covers knowledge and skills around cardiac arrest, but we really dive into leadership, teamwork, and communication skills as well. And we have role plays around reflective checklist debriefing of the team, sharing difficult news. And in the pre-hospital setting, we talk about an OB arrest alert and an SBAR, which is a way, again, of doing a short, brief communication, hand the baton, if you will, off to the team members that are coming to the response or to the receiving facilities. We also developed these proprietary algorithms in order and tools to help both the team leader, but as well as the team when they're talking about potential etiologies. The Back to Life was developed as a way to call out some of the more common etiologies for maternal deterioration and cardiac arrest. And it really is another way of presenting H's and T's, which you may have heard of from ACLS. But really is more focused on the more common things that we see in pregnancy and not necessarily in a patient population that's 60 to 80 years old, which is, what we commonly see with ACLS and H's and T's. And then we do training around all the most common etiologies. So this could look like things like hemorrhage, high spinal, cardiovascular emergencies, as well as overdose, sepsis, and amniotic fluid embolism. So many of those etiologies that Dr. Cunningham addressed, our expert panel really looked at those and said, which are the ones that we really need to focus on? Not only the cardiac arrest situation, but the pre-arrest situation where we need to recognize abnormal vital signs, and also the post-arrest immediate steps that you need to take in order to keep that patient stable and not going into re-arrest. We developed one of our cognitive aids was Alive at 5, which is calling out again the initial actions that you need to take within the first 5 minutes of activating OBLS, performing the left uterine displacement, getting the IV placed above the diaphragm, and that's really just in the arms or neck. In early intubation, again, as a way to reduce the risk of aspiration and help with oxygenation, verifying the gestational age and equipment so that you can quickly extract the fetus in the placenta. And more recently, we've added another E, which is expedite transfer. So we added to the jingle for pre-hospital people. They usually say stroke, STEMI, trauma as reasons to not stay in the field and do prolonged CPR before calling things, but stroke, STEMI, mama trauma, to now suggest that we need to get these patients to a facility as quickly as possible so a resuscitative cesarean delivery can be performed if we don't have a pulse back by 4 minutes. And then we developed our own proprietary cognitive aids to both help the team leader as well as algorithms to help them follow through the steps that are needed for an adequate response. This is just an example of one of the checklists that we use. We have several validated checklists for both EMS, basic, advanced, as well as hospital-based providers. And these go through the critical steps that we, or the expert panel, felt was most important in order to optimize survival in a pregnant patient. Our course is different than other training courses focused either on obstetric emergencies or resuscitation with a focus on pregnancy, just because the whole way we built the framework was based on physiologic changes and the most common etiology. So rather than trying to retrofit those into an existing course, that's really where we came at the development of the course from. We also made sure to embed the most current evidence-based simulation pedagogy, individual and team-based learning principles, as well as mastery learning concepts around simulation and training, and then therapeutic communication practices. We're very intentional, and some of the experts on our panel were experts in these areas. And then we really focused on not only the entire chain of survival, including both pre-hospital and hospital-based contexts, but we really wanted to make sure that we were practicing the way we did things in real life. So interdisciplinary training was really important. And most of our teams that go through these courses are teams that have people from multiple walks of life. So in the hospital base, for example, we might have a nurse from labor and delivery and a nurse from the ER. We might have an ICU doctor, an anesthesiologist, or a CRNA, and a midwife. So we're really intentional about trying to assemble a team that would actually mirror a rapid response team, or on the pre-hospital side, have two respond or one first responder come in and call for backup while they started the initial resuscitation. So we really wanted to try to mirror what was going on in real life. So we did get money from the Agency of Healthcare Research and Quality to fund our work. It was a 5-year, $1.9 million grant where we were able to assemble these experts, 35 from across the United States and Canada. It took a couple of years to develop the curriculum with the guidance from our expert panel, and then we pilot tested it with 88 healthcare professionals and improved on it in years 2 and 3. And then the final years, we performed a randomized controlled trial with 46 participants. These were all the organizations that supported the cause. And we published both our pilot work in one of our major obstetric journals called the Green Journal, or Obstetrics and Gynecology, in 2023. And what we showed here with these 88 participants, again, interdisciplinary participants, over 4 rounds. And after each round, we would make changes to our curriculum manual and Megacode checklist to validate it based on our participant feedback. We also tried to be very intentional about making sure that we hit all the different groups that could respond to a maternal code. And we wanted to really be seeing an improvement in participant confidence scores over the course of the pilot. And what we found is that we were able to improve baseline cognitive scores significantly, as well as produce participant confidence scores. And in fact, in over 54 confidence scores in areas of clinical procedural knowledge and communication, all but one participants showed that they had improvement in confidence. Also, the majority of participants strongly agreed that the course met all its educational objectives. So we knew we were going in the right direction with our work. Here's just a sampling of some of the things we asked them around clinical confidence. We asked, how confident or would they be assessing and managing each of these critical scenarios in pregnancy? So things like amniotic fluid embolism or anesthetic complications, some of the rhythm abnormalities, cyanosis, hypotension. And you can see that for everything across the board, their confidence improved. For procedural confidence, similarly, we asked, how confident do they feel in now managing defibrillation or leading a maternal code, performing left uterine displacement, some of these really critical things. And again, across the board, all our participants suggested that their skills improved, or that their procedural confidence improved, excuse me. And then we asked about communication confidence. How are you able to communicate during a code? How about the ability to lead a debrief after the code, or to share difficult news with a family member? And again, across the board, our participants suggested that our course improved communication confidence. And like I had mentioned before, we asked about the learning objectives, which we had defined and developed at the beginning of the grant. And you can see here that overwhelming number of participants strongly agreed that the course helped them apply theory and knowledge at their job duties, provided opportunities for practicing team skills, appropriate time and facilitation, and met its learning objectives. Some of the discrete feedback we got about the instructors is that they were exceptionally kind, engaging, and provided thorough explanations and were knowledgeable about the curriculum. Some mentioned that was the most comprehensive emergency training curriculum they'd ever taken. That they really enjoyed the continual practice, which reinforced the ideas, and they learned a lot of new things and challenges that they didn't think they would experience necessarily. And then in the class environment, they liked the small size, the ability for more interaction and discussion, as well as the safe learning environment, which is something we really stress and teach our teachers or our instructors on. And then they really liked working together in interdisciplinary teams and felt like that really enhanced their training. More recently, we published our randomized trial in JAMA Network Open last year. And this was a prospective single-masked randomized trial over 12 months. We originally enrolled 46 participants, again, interdisciplinary teams. And the only exclusion criteria was that they couldn't have participated in our pilot testing sessions, and anyone from outside the medical specialties that we had previously defined, we excluded as well. And so I'll just point out again that across the board, the teams that came in and were tested without our education versus those who received our education and then were tested, we saw a statistical difference in their knowledge, their ability to pass the mega codes, their confidence, and then their combined pass rate, which was a combination of both a cut score for the knowledge test as well as the ability to also pass the mega code assessment. And you can see here essentially what this is saying is that if you don't take the OBLS education, and mind you, most of these people were certified in both ACLS and BLS, only 10% were able to pass a mega code that involved a maternal cardiac arrest. But if you took the OBLS education, we could increase that to 91%. And this was, again, all levels of learners. So this included students, both nursing and medical students, as well as paramedicine and EMS workers. So you can see that the course did what it was intended to do. Moreover, we looked at knowledge and confidence over time. And what we noticed is that despite the fact that knowledge remained high up to 1 year after taking the class, knowledge started to wane at about 6 months. So we concluded that, less than 10% of healthcare workers trained in basic or advanced cardiac life support were able to pass a validated mega code scenario. And most of this was due to suboptimal knowledge in either on the cognitive assessment or missing critical elements during the course of the resuscitation, like not performing the resuscitated cesarean delivery within 5 minutes. And that interdisciplinary simulation is effective for improving knowledge, performance as a team leader, and self-confidence skills. This was true regardless of the level of training, and that confidence was retained at 12 months, but attrition of medical knowledge was seen by 12 months post-training. So I'm going to hand it over to Dr. Cunningham.
Thank you. So, based on all this evidence that Dr. Shields just presented, we genuinely believe that widespread implementation of obstetric life support has the potential to increase or enhance patient safety and reduce disparities in maternal morbidity and mortality. But at the same time, we also recognize that additional research is needed to be able to develop strategies to ensure that we could have sustained and equitable access for healthcare workers across a diversity of settings. So to this end, we have 2 ongoing research projects. One is based in New England and is focused on understanding what types of adaptations may be needed to be made to the content and delivery mechanisms for the curriculum to better meet the needs of healthcare workers in rural and other low resource settings. And then we're involved in a statewide dissemination project in Arizona, where we're looking to evaluate a train-the-trainer approach for implementing OBLS across a diversity of healthcare settings. For the New England project, the aims are to identify barriers and facilitators to implementation of OBLS, then to systematically adapt the curriculum as needed, and ultimately implement and evaluate this adapted curriculum in a variety of rural communities across New England. For the first aim, we recruited 122 healthcare workers who were employed by hospital and pre-hospital organizations that serve rural settings. They were invited to watch a video introducing OBLS and completed an online survey. In addition, we've incorporated into the survey and focus groups some of the healthcare workers that we were partnering with in Arizona who actually had experience implementing or had already taken the training and had experience either teaching or and also maybe had experience teaching the OBLS training. Of the 122 survey participants, we asked about a third of them to also participate in 1-hour focus groups. The survey items in the focus group discussion guides were informed by the consolidated framework for implementation research shown on the right-hand side. The consolidated framework for implementation research combines various implementation theories to be able to look at factors across 5 domains, including the intervention itself, in this case, the training, at the individual healthcare worker level, at the institutional level, and even at the broader policy level, to be able to understand what types of processes are positively and potentially presenting challenges to be able to implement this training. Next slide. This is a quick snapshot of some of the survey results, and the take home from this slide is essentially that in both hospital and pre-hospital settings, the healthcare workers who participated in the survey perceived the training to be highly acceptable and appropriate for their work settings. But there were differences in terms of the feasibility, how easy this would be to achieve, and how feasible it would be in terms of whether it's achievable or would be easy to implement. A lot of this came down to resources that are available for training. So in hospital settings, there was fairly strong agreement that there would be space and equipment availability, as well as healthcare worker support for this kind of training, but more mixed feedback in terms of whether there's time for training, leadership support, staffing, and other financial resources. Likewise, in pre-hospital settings, we heard strong support in terms of there being space availability and strong agreement on there generally being leadership and healthcare worker support, but less consensus on the availability of the necessary equipment, materials, staffing, time, and other financial resources. Some highlights from the focus groups pertaining to implementation challenges included consensus on there being limited instructor availability, concerns about the need to balance integrating a new training like OBLS while maintaining system-wide compliance with current training standards. A lot of this had to do with some of what we saw in the survey results in terms of resources pertaining to cost, time, staffing, and other logistics, particularly to be able to do the in-person component of the training. And then some resistance to integrate OBLS just due to a lack of familiarity with the program. We also got a number of suggestions to be able to make this training more feasible and sustainable to implement in rural and other low resource settings. This included conversations where we shared our plans to integrate online learning modules, and we've since developed an online learning management system for handling much of the pre-work for the course, and that received a lot of positive feedback. We also heard consistently that the current instructor to student ratios, which again are 2 to 6 in hospital settings and were 2 to 4 in pre-hospital settings, are very resource intensive and may need to be adjusted. And that is something that we'll talk about in a minute, having addressed. We were encouraged to leverage partnerships across hospitals and systems to share training responsibilities and reduce the resource actually happening in the state of Arizona, somewhat organically even as part of our dissemination study. We recognize a need, and this was reinforced during these conversations about refresher courses. Well, you know, these incidents are rare. It's really important when they do happen to have the appropriate knowledge and skills, right, to address them. So refresher course, similar to what you would see with any other standardized training, is needed. There's very strong support for the train-the-trainer approach to expand access and sustainability. Recommendations to try and embed this into training programs for EMTs, paramedics, and nurses, and then also to explore if there's possibilities to pair this kind of training with other existing trainings, you know, in the form of creating more of a one-stop solution. Based on all of this feedback, we have been working on a number of adaptations and enhancements to the OBLS curriculum, and I'll let Dr. Shields maybe highlight a few of the big ones that are in progress and have been completed.
Yeah, so thank you, Dr. Cunningham. So like she had mentioned, we did do a lot of transition to online. One of the things we did was to develop a website where registrants could go and sign up for courses. Within there had a participant hub created for updates, as well as an instructor hub to serve the same needs of any updates on instructor materials. We developed several online courses, and so I'll just pivot here for a second and say that since we started doing work based on this feedback, we now have 6 different courses. So we have a pre-hospital course that hasn't changed. It's changed a little bit, and I'll talk about some of the additions to that. But we have a pre-hospital course, a hospital-based course for low resource settings, a maternal transport course, a hospital course for high resource settings, an AED only course, and the train the trainer course. So we're really proud that our platform actually offers 6 different courses that obviously have different targets for different customer segments. Additionally, we developed online coursework that mirrored our textbook, but it allowed for more engagement. So we have videos that we've now embedded within there. We have gamification that people can use to kind of test their own skills. And then within the pre-hospital course, some other exciting revisions that we did over the years was to add more about maternal medical emergencies. So we do discuss a lot about how to manage things like hypertensive emergencies while you're in the ambulance, or postpartum hemorrhage while you're in the ambulance, as well as a whole skill station on emergency delivery. So we have an obstetrician or a midwife that teaches pre-hospital clinicians how to attend to normal birth all the way up to things like shoulder dystocia or a breech vaginal delivery. We are also able to increase the participant to instructor ratio for the pre-hospital course to 2 instructors to 12 participants. And that just allows us to scale more easily, as well as I think again, the learning, when you have more learners with different backgrounds, they bring different questions, and it really just enhances the learning overall. We're also testing a modular or longitudinal course. So this is very relevant to places that have a harder time giving learners a full day off, for example. So maybe doing this in elements of 1 or 2 hours over several months might work better for residency programs, for specific EMS personnel in rural locations. That may not be able to travel for a day because of staffing shortages. And so we're currently in the process of developing that. And then our birth centers course is our AED only course. So definitely looking at places that have limited resuscitation capacity, but do have the capacity to at least start with effective chest compressions and ventilation and AED only capacity. We piloted that actually in a birthing center in Phoenix, and that went really, really well. And we taught over 12 midwives or birthing assistants and doulas there, and it was enjoyed by everyone. We also are developing a refresher course that we're really excited about for all of these courses, and that we're going to be testing as well and validating. We developed implementation guides for scaling. So when we do, for example, train the trainer in a region with handpicked participants who will become instructors, the implementation guide helps future course directors implement our courses within their context so that they can continue to sustain the training, and it doesn't require an OBLS national faculty. It requires, a local instructor who has a teach back and then can continue teaching their people. We've had several simulator updates. So like I'd mentioned before, we worked with an international simulation company to develop a maternal cardiac arrest simulator, but we also have alternative solutions when, for example, if that simulator is not affordable or not available for sites to develop on their own. We do have some high fidelity equipment solutions as well, like the iSimulate defibrillators that are essentially iPads that can show different types of defibrillators on the market, and use those to be responsive to what the teams are actually doing, rather than having for example, just a still monitor card that we show. And so we do have both high fidelity and low fidelity solutions, depending on, again, cost being a barrier. And then we are working on course incentivization. So for example, on the pre-hospital side, we're applying for CAPC credits and accreditation, and then continuing nursing and medical education credits as well. For the obstetricians in the room, we got approval to be a type 4 credit for the maintenance of certification. So that's just another thing that participants receive when they get through the course. So Dr. Cunningham, am I continuing or are you going to take over?
I'll do this one.
Okay.
I'll get through the research that we're doing now.
All right.
So, at the same time that all of this great work is happening to identify some of the factors that may be influencing implementation and begin adapting the curriculum and developing these enhancements, we've been working in partnership with the Arizona Perinatal Trust and the Arizona Emergency Medical Systems to identify and train healthcare workers from hospital and pre-hospital contexts across the state to be OBLS instructors, and then have these newly minted instructors go and provide this training at their home institutions. And we are about to start our evaluation process of how this is, of what this looks like, both in terms of the extent to which we've been able to reach healthcare workers in the state, and also what various process outcomes look like at the institutions where people have been trained. The work under this grant, this type of research is happening in 2 phases. So we are just completing are wrapping up cohort A, which began in 2024 with the identification of individuals who would become OBLS instructors. Those individuals have spent the last year conducting trainings at their various home institutions, and we're in the process of evaluating those outcomes and preparing for phase 2. And it was a very deliberate choice to have 2 separate cohorts because we anticipated that we would learn a few things along the way as we started this process with our first cohort that we could apply moving forward. This next slide just shows the phase 1 and 2 implementation sites across the state. And there was a deliberate effort to focus on rural areas and places where the rates of maternal morbidity and mortality were highest. So we're proud, in the last year and a half or so, 71 OBLS courses have been completed, and you can see what that looks like across the hospital-based, pre-hospital, and critical access courses. We've trained a total number of 353 healthcare workers with a 90% pass rate. A large proportion of these healthcare workers were deemed eligible to become instructors. And we've offered, these data are as of July 2025. So as of July 2025, we conducted 15 train the trainer courses and had 41 new OBLS instructors. You can see a variety of different training locations. Most of them have occurred in, well, not most, but half of them have occurred in Arizona, but between the New England grant and the opportunity to disseminate about OBLS and the work that we're doing in both those settings, we've also been able to train individuals in other settings. The training has been extraordinarily well received. Here you can see very high proportions of hospital-based and pre-hospital healthcare workers who report that they strongly agree with having been felt prepared, for example, to take the course. That the training experience met its educational objectives and was engaging, and that they would recommend it to others. And although not everybody desires or takes the course with the intention of becoming an OBLS instructor, we had a very high proportion of individuals who said that they hoped they could be. Similar to some of the testimonials that you saw from the pilot study, our evaluation data again suggests that there are a lot of benefits for the OBLS training, including stretching one beyond their comfort zone, being able to practice in a team lead role. The instructors receive very positive feedback about how they run the trainings. The hands-on practice is very highly valued across implementation settings. And this, specifically the rapid cycle deliberate practice element to it and the judge-free atmosphere. That said, there's always room for improvement. And so some of the feedback we got in this regard was a request for more lecture time, so a more didactic component to it, having fewer mega codes, more coverage of maternal health and physiology, and with the online learning portion to continue to work towards making it as interactive as possible. At the end of August of this year, we met in Flagstaff, Arizona with our partners and the representatives from each of the implementation sites for the phase 1 work. So there were 5 different settings in which individuals had become trained to be OBLS instructors. And we came together to see what we could learn to help inform the next cohort's experience. And so this slide summarizes some of the comments that were shared as each of these implementation sites gave presentations on what their experience had been like. Key successes including that there was very high engagement and strong outcomes, 100% pass rate at multiple sites, very robust participation among different types of learners, and overall participants reporting they felt increased preparedness and confidence to be able to handle maternal medical emergencies. People responded very positively to the multidisciplinary way in which the training occurred and found that that did foster shared learning. And then the spikes communication training was mentioned by several of the implementation sites as being particularly well received, especially among EMS providers. So this is, correct me if I'm wrong, Dr. Shields, the kind of debriefing and sharing difficult news components at the end of the training, or at the end of their hands-on simulation practice. What else is here? We had very strong institutional support. You know, that's expected. There was a selection bias. You know, we worked closely with each of these sites to identify places that would be excited to incorporate the training, but nonetheless, it was nice to see that that was maintained over the time. And many of the initial sites plan to integrate OBLS, actually all of them plan to integrate OBLS into ongoing staff training, onboarding, and simulation labs. Some of the challenges and lessons learned from the first phase of this work centered on implementation logistics. So we did run into scheduling conflicts and limited simulation staff, and you know, in some cases, conversations about you know whether or not, or I guess in this case, that people weren't going to be paid extra to do the trainings or participate in them. There were some challenges with internet and simulation supplies and access to instructor materials that had to be worked around. There was feedback, particularly from pre-hospital participants, that they felt that the content was skewed more towards hospital settings, and so requested that we consider incorporating more EMS-specific questions and examples. And then, you know, we're always working towards improved coordination and communication, in this case among leadership at these individual institutions, the instructors, and also the research team. And I will now let you wrap up, Dr. Shields, with next steps.
All right, thank you, Dr. Cunningham. So for Arizona, like Dr. Cunningham mentioned, we are getting ready to do our second cohort. And again, most of the sites are concentrated in Northern Arizona this time. So we'll be using the similar train the trainer approach as the first cohort, or we're planning to train over 100 instructors in 2026. We have 8 implementation sites that have been identified by the Arizona Perinatal Trust and Arizona EMS. And these, again, were targeted to focus on those who are serving remote regions or underrepresented in Arizona. And our target is to train more than 400 healthcare workers in these regions between 2026 and 2027. So super excited about this and super excited about our future partners that they've identified who are very, very eager to bring this to their sites. Additionally, we are developing our refresher course, like I had mentioned. It's going to be an interactive scenario case-based online course that we're going to be giving. And then we're going to actually be doing a randomized trial in the Northeast to look at how that course compares in terms of skill maintenance and having to take the full course again every 2 years. So we are going to have participants receive baseline full course training. And then we're going to randomize them at 24 months to either receive an abbreviated refresher, the full course, or no refresher at all. And then we'll assess them both in skills and knowledge and confidence and see what our results are. So we're really excited about this. There's very, very little research or science in this space in general. So I feel like we're going to be pioneers with seeing if this is an adequate way, or what is the adequate way to deliver refresher training. So like I'd mentioned before, we did revise the pre-hospital course. We have piloted that with the more desirable instructor to student ratio. And I can report that we've trained about 48 people in the new piloted course, and we've received, again, generally similar pass rates and increased satisfaction. So it's been exciting to see that. And our pre-hospital clinicians are very excited that we've added obstetric emergency training, as that might be something that might be even more common than maternal cardiac arrest, and that they feel little confidence around, as well as just the management of some of these severe maternal emergencies that, especially in places in Arizona where they might have commute times of upwards of 1 to 2 hours. And so you can imagine in those situations, many of you listening probably are in those situations where you're having to manage a critical mom for that length of time, having the skills to be able to do that, and then being able to actually make some system adaptations when you receive the training, to go back to your chiefs or to go back to the state level and say, hey, we need to add some things like tranexamic acid to all the rigs in Arizona, or maybe certain antihypertensive medications that we, under the direction of our medical director, may be able to provide to these pregnant moms so that they don't stroke, for example. Like I said before, we are working on course incentivization, and we know that some of these are required for annual certification. So we're really excited about that. There's something called Quality Matters. It's a certification for all online courses. It's very common in the university setting to standardize the delivery of online education, but it's what we use to develop our online education. And so we're seeking that certification as well, just as another layer of quality for the way we deliver education. And then we also are in discussion with several large membership organizations about endorsements. And so we'll be excited to announce those when we finally have those agreements in place. Also the train the trainer course that we talked about, the modular curriculum we've talked about, and then just developing alternative lists for equipment needs, and how we can, again, improve access in terms of low cost tools that can be used to support this course. We do have a annual course that we deliver virtually. In the past, it's been free. We hope to keep it free. And so we have one coming up on February 6, 2026 on it's the same day as Go Red for Women Day for the American Heart Association. So we're kind of promoting our 4th annual course. This one I'm very excited about. So this one is going to be patient focused. So we're going to have several pregnant and postpartum patients who have had significant morbidity or have undergone a cardiac arrest come with their physicians or their EMS providers to talk about their stories. And we'll have a little didactic on, whatever was affecting them, as well as just some focus on perinatal trauma and things we can do to support our patients and their family and caregivers after the fact as well. We're just going to leave you with this quote. This is from the president of the Federation of International Gynecologists and Obstetricians. Women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And this is just calling out the fact that we need to really focus on the women of our country. In fact, I just looked at some science today around the economic cost of maternal death in our country. And the number was staggering. This was from 2020. The maternal death, the economic cost of maternal death that has to do with, loss of workforce, things like that, is $165.3 billion. That is not a small number. And I think if, obviously the emotional appeal isn't there, there's an economic appeal to save these lives. And while it's fewer in number than what we see in the older range from cardiac arrest, it has a tremendous impact, both emotionally, and economically to our societies and our communities. This is our website, www.obls.org. If you want to go there and get more information, we have some promotional videos on there. There's links to the manual. The manual still can be downloaded for free from CRC Press. So please go get your free downloaded manual and take a look. And if you have any questions, Dr. Cunningham's is not up there, but we're certainly happy to provide both of our contact information. We've got references on the slide, and then we'll take any questions. So thank you. Thank you for your time.
Thank you guys both so much. I want to give you a round of applause for how fantastic you were as presenters. Every question that came in, you guys quickly answered on your own. So a lot of them had to do with the refresher course and how you're managing that attrition. And you explained that well with your trial that's coming up. Additionally, there's some comments on how excited people are for it to be attached to certification, as that's a lot easier to get admin on board with. So it doesn't look like there's any questions left unanswered, which is a really big kudos to you guys as presenters. So thank you both. And I will include these slides with your contact information if anybody has follow-up questions afterwards, as well as the information about that conference coming up, that virtual, hopefully free conference, in case anybody wants to attend that as well. So thank you both for your time, and thank you everyone for attending. Have a great day.
Thank you.
Thank you.